Hello and welcome. Today we're diving deep into the management of chronic hepatitis C. We're going to walk through the whole journey, from what it means to have a persistent viral diagnosis all the way to a near-certain cure. And let me tell you, it's a true revolution in modern medicine.
And just to be clear, all the content in this explainer is based on the fantastic clinical review by Dr. Mohammed El-Menaji Mohammed. We're using his framework to guide us through the essentials of Hep C management. All right, so here's our game plan. We've got 5 parts. First, we'll nail down the definition of chronic disease. Then, we'll get into its clinical consequences. After that, we'll look at modern therapy principles, the drugs that changed everything, and wrap up with some crucial patient counseling points. So, let's get started with the diagnosis.
So what exactly is the diagnostic criterion? I mean, at what point do we say, okay, this is no longer an acute HCV infection, this is a chronic condition that we need to treat?
Well, it all comes down to one single time-based factor. It's not just about the virus being there. It's about the documented persistence of its RNA in the bloodstream. That's what officially defines the chronic state.
And that specific time frame is 6 months. This is the clinical line in the sand, you could say. It's what separates a self-limiting acute infection from a chronic disease that carries all those long-term risks and really demands a clear treatment strategy.
Now that we've defined it, let's talk about why that 6-month mark matters so much. The whole reason we're so eager to treat is to prevent the really significant long-term problems the disease can cause, both inside the liver and, well, outside of it too. Of course, the complications everyone knows about, the ones we fear the most, are hepatic. They happen in the liver. That chronic inflammation from the virus just damages the liver over time, leading to fibrosis, then cirrhosis, and eventually a much higher risk of hepatocellular carcinoma.
And we can actually put numbers on that risk. Now, it's not like every single patient will progress to end-stage disease, but a pretty significant chunk, we're talking up to 1 in every 5 patients, will develop cirrhosis because of their chronic HCV. That statistic alone really shows you why intervention is so important.
But, and this is so vital to remember, hepatitis C is a systemic illness. It is not just a liver disease. We see a whole range of issues outside the liver. These can be anything from rheumatological problems like arthralgia to kidney disease, specifically membranoproliferative glomerulonephritis, and even those classic vasculitic findings you see with type 2 cryoglobulinemia. Honestly, sometimes recognizing these is the first clue that points to an underlying Hep C diagnosis.
Okay, so understanding all those risks, the goal of modern therapy becomes crystal clear, right? We have to eradicate the virus to stop these complications in their tracks. So, how do we actually do that in the clinic today?
The modern pathway for management is, thankfully, super streamlined and logical. It's really a 4-step process. It all starts with one crucial first step, testing the viral genotype. That test directly tells us which therapy to choose. Then, we start the treatment, we monitor the viral load to see how it's working, and we aim for that ultimate goal, a sustained virological response, or SVR.
SVR, you'll hear that term a lot. It is our primary endpoint. Clinically, SVR is considered a cure, and the definition is very precise. It means there is undetectable HCV RNA in the serum, and this is measured 6 months after the patient has finished their entire course of therapy.
The journey to being able to reliably achieve SVR is, it's truly one of the great success stories of modern medicine. The whole therapeutic landscape has gone through a complete paradigm shift in just the last couple of decades.
And this slide really shows you the scale of that revolution. It's night and day. We moved from the old interferon-based era, which was a grueling treatment, known for awful flu-like side effects, neuropsychiatric issues, and honestly, pretty low cure rates, to today, the era of direct-acting antivirals. These DAAs are not only incredibly effective, they're also incredibly well-tolerated. Interferon? It's basically a relic of the past for Hep C now.
And this number says it all. With the DAA regimens we have today, we can expect cure rates of around 95%. That's huge. It has completely changed our approach from just managing a chronic disease to achieving a definitive cure for the vast majority of our patients.
So today's standard of care is all about combination direct-acting antivirals. They often target multiple parts of the viral life cycle. We choose regimens like daclatasvir plus sofosbuvir based on that initial genotype testing, though a lot of the newer regimens are now pangenotypic, which makes treatment decisions even simpler. And in some specific cases, we might still add ribavirin to these combos to really maximize the chance of a cure.
All right, let's finish up with a couple of key clinical pearls. Specifically, let's talk about the really critical counseling that's needed when ribavirin is part of your patient's treatment plan.
So if you're prescribing ribavirin, there is one piece of safety information that is absolutely 100% non-negotiable. It is the most critical counseling point you can make for that patient's safety. What is it?
Here it is. The crucial point is that ribavirin is teratogenic. It can cause severe birth defects. This means female patients must be counseled on the absolute need for effective contraception during therapy and for a full 6 months after their very last dose. That ensures the drug is completely cleared from their system.
Now, beyond its teratogenicity, which is the big one, we also need to monitor for other well-known side effects of ribavirin. The most significant is a dose-dependent hemolytic anemia, so you'll need to do regular blood counts. And patients might also report a persistent, pretty annoying cough, which is good to mention during counseling so they know what to expect.
This quote really just sums it all up, doesn't it? That leap to a 95% cure rate is a monumental achievement. So, the final question this leaves us with is this. What does this triumph mean for the future of liver disease, for transplantation, and for that global public health goal of eliminating viral hepatitis altogether?